So continuing our project where we have motion as the central point of our network of meaning or of our semantic network when attempting to understand anatomy or learn anatomy, we're going to look at forearm rotation. Now, we use the term forearm rotation because we're going to talk about rotation in both directions of the forearm, with the common terms being pronation and supination. So first, we consider the anatomical position, which is the arms by the side and the palms up, and that, or the thumbs out, right? So palms up here is not necessarily what we're talking about, because if the arms are at the side, it would actually be this way. So it is thumbs facing away from the midline. So palms up, arms at the side, that is considered a supinated position. So if I were to put my hands up like this, just raise them, we have this as a supinated position. And then we have this as a pronated position. So supination is rotation away from the midline, more or less, and then pronation is rotation towards the midline from the anatomical position. Okay, so we just have those two terms, but we'll use the broader term forearm rotation to describe both. So our main objectives rather, a specific discussion of what forearm rotation is. So we've already broken down supination and pronation, but we'll talk about the planes and the axes. General discussion of the muscles that generate rotation of the forearm, general discussion of the nerves that supply those muscles, general discussion of the vascular supply, general discussion of the areas to assess and treat should issues with forearm rotation be suspected by the practitioner or reported by the patient. So our quick overview of planes. So we have the sagittal plane, which is a 50% cut of the body left to right. We have the horizontal or transverse plane, which is a 50% cut of the body top to bottom. We have the frontal plane or the coronal plane, which is a 50% cut of the body back to front. Then we have the axes, which are perpendicular to the plane. So the sagittal plane has a transverse or horizontal axis. The horizontal or transverse plane has a vertical axis, and the frontal plane has an AP or APA axis. So in this case, forearm rotation, especially from the anatomical position, is going to occur in the horizontal or transverse plane on a vertical axis. And that is primarily determined by the relationship between the radial head and the humerus. So the radial head, being contained inside of the annular ligament, is able to rotate essentially generally around the ulna. So the radius is able to rotate around the ulna, or they cross as the head of the radius rotates in relation to the humerus. Now, the surface of the radius there is essentially mildly dished and round. So it's able to create that rotation. So essentially, the likely axis is determined by the muscle pull, the annular ligament, and the relationship between the humerus and the radius. So it's going to rotate or generate rotation in the transverse or horizontal plane about a relative vertical axis, which is determined by the annular ligament, the shape of the bones with radius and humerus, as well as the muscles that are going to pull to generate supination and pronation. So the muscles are almost all visible on this slide. So the biceps brachii and the supinator are your primary supinators, or muscles that will generate supination. The brachioradialis is also considered a somewhat weak supinator, but it will take part. Then as far as pronation is concerned, you have pronator teres, which is visible here on the middle cut, and then you have pronator quadratus, which is not visible here. Pronator teres and pronator quadratus are going to be responsible for pronation of the forearm. Now, the neurovascular bundle here, so we're really looking at the radial and median nerves, as well as the musculocutaneous nerve, because the biceps brachii is one of the primary supinators. So the musculocutaneous nerve is involved, the median nerve and the radial nerves are also involved, depending on the specific muscles that you're looking at. And the circulatory, on the arterial side, the circulatory pathway is going to run from the brachial artery supplying the biceps to the split of the radial and ulnar arteries, as well as the radial recurrent artery and the anterior interosseous artery. So you've got a bunch of arteries, but your primary circulatory pathway is going to be on the anterior surface of both the arm and the forearm, right? So you're looking more or less at the biceps and the anterior surface of the forearm as the places that can put mechanical forces upon the neurovascular bundle. So the veins would essentially travel in a very, very similar path But because you're more or less looking at the anterior surface of both the arm and the forearm, the neurovascular bundle relates quite well. It's not particularly confusing here with respect to the motions of pronation and supination and the muscles, the nerves, and the arteries that are going to supply that motion. Now, really simply, as I already noted, the areas of consideration for assessment and treatment, because the arm is supplied off of the brachial plexus, you're going to look at the cervical column. So you're looking at the neurovascular bundle. So there if you're thinking about the cervical column with respect to the nerves, you're thinking about the brachial plexus. So then you're going to have to follow that down posterior or in between the anterior and middle scalenes. So again, you're thinking about the cervical column, then you're thinking about the clavicle. Then that, as it travels posterior, then it goes into the axilla and then down more or less the medial portion of the arm. So in more or less medial to the biceps. Now, not completely, but that's why the biceps becomes very important. So that anterior soft tissue. So here you're just thinking about the nerves, but luckily the artery travel, or the artery and the nerve travel very similarly. And then you're thinking about the anterior soft tissue of the forearm, not only for the muscles that are going to generate supination and pronation, but also for the neurovascular bundle. So if you're thinking about the vasculature, then you're thinking about the subclavian artery as it passes between the anterior and middle scalene. So again, you're thinking about the neck, it goes posterior to the clavicle. So you're thinking about the clavicle, you're thinking about the axilla as it becomes the axillary artery. Then as it relates to the bicep, you're thinking about the brachial artery. Then once you get to the elbow in the region of the median cubital fossa, you're thinking about the split between the radial and ulnar artery, the radial recurrent artery, and the anterior interosseous artery. So for supination and pronation, not only you're considering the motion, but you're considering the neck, the clavicle, the axilla, the anterior soft tissues of the arm, and the anterior soft tissues of the forearm. So those are the areas that you're going to want to pay quite a bit of attention to because of not only the motions, but the neurovascular bundle. Now, as far as contraindications and red flags, a known fracture or a known tear is do not treat the area. Doesn't mean you can't treat the patient, but the fracture or the tear, as you treat it, you're going to cause aggravation and possible further damage. Suspected fractures and suspected tears, you refer out for confirmation from another medical professional who can take another look at a level that you're unable to as a hands-on practitioner. So again, known fractures, known tears in this region, don't treat. Suspected fractures, suspected tears, refer out. Now known fractures and tears don't treat the fracture or the tear. You can treat the patient, but it doesn't necessarily mean you're going to deal with the issue. You may help the patient. The suspected fractures or tears, you need confirmation. You need to send that out.